Good evening, everyone. Here, Imran Abbas from Dubai. Again, we are with another session with another legend, Professor Karl from Germany. And today, again, we will continue our series of MGB, OAGB. So we will try our best in our discussion to talk about MGB, OAGB, and hopefully this our discussion will be helpful. So I will not take your time. Professor, highly welcome, and over to you, sir.
Okay, thank you very much, Professor Imran Abbas, for this. Thank you very much indeed for this honorable invitation.
Yes, sir. Thank you, sir. Sir, this is the routine, what we do, because there are many repeated questions in this session. And what is our target, as we have discussed earlier? So we will continue our series of MGB, OAGB. We have started with the legend Professor Robert Rutledge, who is pioneer of MGB, and also we will end this series with Professor Karl, who is also another legend. We know better. So now there are two peaks. So one is MGB, mini gastric bypass, and other is OAGB, or one anastomosis gastric bypass. There are some little technical differences between these two techniques. So, but most of us, as I till this time, I have discussed with many of the bariatric surgeon. So we have some points from Robert Rutledge and some points from Karl. It depends on our experiences. It depends on our patients, and we are going ahead. Sir, first of all, our main question is your brief introduction, because people want to know about you.
Okay, thank you very much for this introducing words. Very, very nice. Actually, I am based in Cologne, in Germany, in a public hospital. Cologne is the fourth biggest city in Germany with 1 million inhabitants. And I started my medical studies in 81, last century. So I did it mostly in Germany, and the final year I did in South Africa at that time. And I got my medical doctor in the year 88, and then I started. At that time, I started as an assistant surgeon in a big public hospital. Actually, at that time, the specialties of surgery were still under one big chief. So we got traumatology, orthopedic surgery, vascular, thoracic, visceral, general. All was with a 220 beds unit in a huge hospital. That was where I started my career to become a surgeon. And in 96 I became a general surgeon, and this career was interrupted by 2 years of volunteer service in Western Africa, in Burkina Faso, where I did surgery as well, so more on a general basis. And after 96, I did some step away to the trauma surgery, so to the bone and joint surgery, to become an orthopedic surgery, where I was very much focused during 4 years, and then coming back to general surgery and visceral surgery, and coming into touch with bariatrics, with the gastric banding in the 90s. That was actually in the 90s. Gastric banding was the only option, the only method in Germany to do bariatric surgery. There was nothing like gastric bypass at that time. It was actually not known at that time in Germany. There came some very few surgeons did did vertical vertical banded gastroplasty, actually only one center in whole Germany. And then bariatric surgery started actually in Germany very, very late. It was Rudolf Weiner, of course, who was our first president of the German Society for Bariatric Surgery, who started this and who brought it up actually. And myself, I was focused on the visceral surgery from the year 2002 onwards, and in 2005-06 I started to focus on bariatric surgery. At that time it was quite like a pioneer job in Germany to do this. There was very few centers, and it was very difficult to get some experience and to get training. At that time, of course, we did many operations laparoscopically, like the anti-reflux surgery, fundoplication, even colon surgery, colorectal, gallbladders, appendix. All this was done laparoscopically, as well as the hernia surgery. But bariatric, we had not many ideas of that, so I was forced to do some visits, some hospitations in other countries and to see how to do and to learn how to do bariatric surgery, because it's very important to learn before you do the procedure on your patient. So I have been like to Karl in Austria, who was one of the former presidents of IFSO also, and there I was trained doing gastric bypass surgery with Rudolf Weiner. And then in 2009, I had some visiting time in Paris with Professor Jean-Marc Chevalier, who was, we can say, the president, or yes, he was the president of the French Society for Bariatric Surgery at the time. At the moment, he's becoming the European chapter president after Gerhard Prager. And actually, at that time, I already did some bypass surgery, some sleeve surgery, bending, and so. And in 2009, being in Paris, I watched Professor Chevalier doing gastric bypass, and I said, "But what are you doing? Where is your second anastomosis? And your pouch seems to be quite long." So at that time, he explained to me what he's doing, and I learned about one anastomosis mini gastric bypass, and he explained me the advantages and why he shifted actually from Roux-en-Y gastric bypass, which he did before, to the one anastomosis gastric bypass. So that was quite experience. I had heard of it from literature, but in Germany at that time it was not practiced. Actually, Rudolf Weiner, he did a small series very early in like 2007 or so, but he was quite disappointed, and I think he did perhaps another technique, or with a quite shorter pouches at that time, and he had a lot of reflux, and he published this in a standard textbook in German language concerning bariatric surgery. And this procedure was at that time quite obsolete, we can say. It was almost forbidden at that time. And so when I started, I started my department at Cologne in 2009, and in the beginning, I did not dare to perform mini gastric bypass, because the procedure was so under observation that it was not possible with a new center to start with a so-called experimental procedure. So I stuck to Roux-en-Y and to sleeve gastrectomy and a few gastric bendings still, but I did not do the mini gastric bypass. It was only in 2011 I remembered that I had this experience with Professor Chevalier in Paris, and I started doing my first mini gastric bypass, actually in a super obese patient, because I thought that's too difficult doing Rheinwalt gastric bypass. And so I did this procedure, 2-3 procedures in this year, and it was perhaps by luck that Professor Rutledge in 2011, it was the IFSO World Congress in Hamburg in Germany, and in September I think he was writing a mail to the bariatric surgeons in Europe, and included me, and he was offering to come to visit surgeons and to show them about mini gastric bypass. And at that time, in October 2011, I was one of only 2 surgeons in the whole of Germany who accepted to receive him and to have him a couple of days in my center. And he showed me many videos, he showed me many details. We operated together, which was quite a very important experience for my further career at that time. I remember in one day he was writing from in one day 12 abstracts. So he's a very hardworking person. He was not interested doing any tourism or so. I said, I will show you a bit around, because Cologne is an old Roman city. Actually, the Romans have been there for some time, for 1,800 years ago. The Romans have been there for some time, and there is a cathedral also. There is this twin tower, big cathedral, this big church, and I wanted to show him, but he said, if you don't mind, I did not come for tourism. I came to teach you MGB, and I have many videos, and I will give you a choice which video we will start to teach you. And so we were hardworking all the time from morning to evening. So it was quite a very marking experience in my professional career to coming across with Professor Rutledge. And few years later, actually at that time in 2011, end of 2011, 2012, I started introducing MGB in my portfolio, in my variation of offered bariatric procedures for my patients. But still, I had to be very careful, because even if it looked great, the procedure to me and to Robert Rutledge, of course, but for the officials and for the more experienced senior surgeons in Germany at that time, for the society, and so I became a person to be observed, a surgeon being observed, because I'm doing some kind of new surgery. And so I started giving presentations in the German congresses and so, and I had to be very careful with my presentations, and I could never say it's a standard procedure. So I had to say it's a procedure for selected patients, and I had to select my indications at that time. And actually I did like an algorithm, and I offered MGB only for patients from BMI 50 to 60. So meaning up to BMI 50, we still did the Rheinwalt gastric bypass, and sorry, and then for the high BMI 60 upwards, we did the sleeve, and for 50 to 60, we tried to offer MGB. Before it was with a BMI higher than 50, usually we did sleeve only.
Sir, excellent. So we will discuss about indications and as well as contraindication. And as you have mentioned, I know Professor Rutledge is really hardworking, and we must acknowledge, because every time, when I sent midnight message, same time he respond me, and really all the time, and day and night. And also I was talking him, he's eating, he's drinking, everything is MGB. And so I am very positive. So when now discussing with the many surgeons all over the world, so there is a positive response for MGB, because one thing that is the most important, we all are scientists and our patients are more important. If we are taking good response, then we are going ahead for MGB. Sir, one question, now more than 1 decade, so you are practicing this MGB during this period. One question now in your practice, what is the percentage of MGB? So if you compare, yes, it is 20% of total, 30, 50 or something like this. And same, I will extend my question. So during this 1 decade that you are practicing, have you changed your technique for better results? And if you change, so why you change? So there was length, as earlier you have mentioned, because at early stages this gastric pouch was short and more complication. Now the length of pouch is lengthy. So then, as well as this JJ, this gastrojejunostomy, so maybe any change you did during this period? And what is the percentage of MGB in your practice now?
The percentage of MGB now has become about 50 to 55% of all bariatric procedures we do. We do about almost 20% is revisional redo surgery, because we got a center of excellence. So many patients who are having redo surgery are coming to us. And but of the total of our operations, 55% are MGB, and the rest is varying. Some sleeve, some Rheinwalt. The other procedures we do rarely, like this BPD, duodenal switch, SADI, so very rare. Especially these highly malresorptive procedures are not so popular in Germany, because the follow-up is not good in Germany, and there are many problems concerning the supplementation and the risk of malnutrition, and so. You were asking about the technique, if I changed the technique. Of course, I remarked that in my first self-guided operations in 2011, I did the pouch too short, because there was tendency to cut to partially divide the stomach like above the angulus. And so the pouch is getting too short, like 10, 12 centimeters, which is not good, which is creating a lot of reflux problems. So after the visit of Professor Rutledge, we did much longer pouch. So the pouch is going, I will show later in a video, perhaps, if you like. We will go down below the incisura, below the angulus, so about at the first third, between the first third and the second third of the antrum, we are dividing the stomach. And change we did actually is the length of the BP limb, because in the beginning, because we have many super obese patients in Germany. So we got one of the highest average BMI in the world in Germany, which is quite surprising perhaps, but it's a fact, because we are not operating very high numbers in Germany. If you with regard to the high incidence of obesity, so meaning our BMI is in average 49, which is very high, and so I adapted our bypass length to a paper coming from Wai-Chi Lee from Taiwan, and he did very long bypasses. It was actually a BMI confectionated algorithm. So we we did the length of the BP limb. Usually we started with a 200 centimeter was a standard for patients like below 45, and above 45 we did 250, and we did even higher with 60 with a BMI 60. We did 3-meter bypasses, and we got patients even much higher up to BMI 75. We did 350 centimeters. And actually we got quite good results, but then this very long bypasses became very much criticized when the years went by. And we remarked also that we did not get dramatic side effects like liver failure caused by too long bypass or so. But we remarked that we had a lot of hyperparathyroidism. So with a lack of calcium, we got lack of vitamin A. The fat-soluble vitamins were going down. And actually, patients in Germany, they don't go routinely for the lab values. They came with a problem. So they came, doctor, my sight is getting bad, and we measured, and the vitamin A was almost not measurable anymore. And problems like that, and with the iron also, with the lack of iron and the anemia. And that's why we went down with a bypass length. And a few years ago, like 5 years ago, we started doing 150 centimeter bypass for the standard patient up to a BMI 50. And above BMI 50, we are doing 200 centimeter bypass. And we don't do longer bypasses anymore. Unless in the redo surgery or in revisions, meaning like if you have a sleeve patient to be revised to mini gastric bypass, we are measuring the total bowel length and are confectionating the length of the BP limb according to the total length of the small bowel, which might vary very much as we know. It's about between 3 meters and 12 meters in the literature. So, which might be dangerous. Yeah, we know there are a few case reports with a very bad results, with a long MGB, with a 3 meter total bowel length, and these are exceptions. But still, it's a good idea, I think, to not to do more than 200 centimeters if you don't measure the bowel downwards, or at least you should perhaps measure the efferent limb a length of like 3 meters going downward if you don't want to measure the total bowel limb length. That is one issue in our technical changes. And the other issue was, which was for me very striking, was the fact that the lower end of my pouch was very often twisted. So meaning the minor curvature at the end, so the first staple line, there was a stapling start at the minor curvature. It was coming up ventrally. So the pouch was often twisted like 90 or even more degrees. And I never understood. Long time I thought it might be the anatomy of the muscle fibers in the stomach, which have the tendency, which have tendency to twist the pouch in this way. And a long time we did an anti-torsion stitch. So meaning I stitched the minor curvature of the pouch with a stitch to the anterior wall of the antrum to have this anti-twist effect. And it took some time for me to learn, because I did not find this, or perhaps I did not watch 100% enough Professor Rutledge by doing. So it is important to, this first stapling line is very much important. So you have tendency to grab the anterior wall of your stomach, which means your staple line starts not at the minor curvature, curvature, but it starts just in front of your stomach, so at the anterior wall, which is causing this kind of twisting. So to avoid this and to have a flat non-twisted pouch, you have really to be aware to start to put your stapling coming from the minor curvature and to pull actively with a instrument the minor curvature into this part of the pouch of the stapler.
Sir, excellent, really. So these were the in my opinion, very technical points and very important, because if someone is going to start this MGB, these 3 points were very important: length of pouch, length, this BP limb, that is the most important, and also maybe it varies. So countries to countries, culture to culture. So it depends on the dietary habits of the patient who is living in India and vegetarian who is living in Europe and using more protein, maybe little length, that is debatable. But overall, length of BP was very important. And that point that you have mentioned is first stapler. So yes, we will go ahead and we will talk about this. Definitely, we like to know, and also me and also viewers are interested to see your videos. But before reaching that point, so I have some other questions, sir. So now you know better, because just today IBC platform, that was an excellent debate about marginal ulcer, and definite there are some concerns. So the main concern after MGB, like marginal ulcer, GERD. So GERD, I know this is a vast definition of GERD, but overall GERD, that may be bile esophagitis, bile gastritis, marginal ulcers. So these are the, and malnutrition as well as liver failure. So these are some things, and then at the end, gastric carcinoma. So if you remember, if we just, I can imagine 1 decade before, these were very highlighted, and we always discuss about MGB. When MGB, this concern was very dominant. Now in 2021, are you think so about these concerns or no? There are, what is your opinion, sir, now?
You are right. Perhaps the concerns are a bit settled because we have only very few cases with a cancer problem following the mini gastric bypass, and there are only these 2 or 3 case reports in patients, and these are very I will not say silly, but it's are cases which had no gastroscopy before the operation, and with a cancer appearing very shortly, a couple of months or 1 year only after the operation. So in these cases published, it was obvious that the cancer has been already started probably before doing the one anastomosis gastric bypass. So I think we cannot give a final answer about the real risk or additional risk of having some gastroesophageal malignancy. In my opinion, the pure gastric malignancy, the risk should be very low, because it's somehow physiological that bile juices are entering the stomach, even in your patients following cholecystectomy.
Yes.
They have a lot of, usually they are used having bile in their stomach, and all the other ulcer operations like Billroth's operations, they have bile in the stomach. Vagotomies have bile in the stomach, so probably the stomach is quite resistant to bile. But I see it is another issue is bile in the esophagus. Esophagus is not built to withstand continuous bile exposition. So this is this is a risk. It's a risk with not only with one anastomosis bypass, but perhaps even more with a sleeve gastrectomy, which has become the most frequent operation in bariatric surgery. And I mean, it's not a frequent problem with mini gastric bypass having bile reflux, but it's not zero. So we have some patients, and it might come up even to 5%. In literature, it's 1%, 2%. But on the long run, if you do, now we are doing this procedure 10 years, I would estimate now it will, with a longer time, it will reach like 5%. But still, it does not discredit this procedure, because there is there are conservative means to treat it, and of course you can treat it with a revisional surgery by doing conversion to Rheinwalt gastric bypass, or Professor Rutledge is recommending Brown's anastomosis. But I mean, you can divide the bile juices to the efferent limb and to avoid the bile going up, and you can do anti-reflux surgery as well, which of course will help to stop the bile juices from going up into the thorax, into the esophagus. But we know from the gastric surgery, from the Japanese cancer surgery, they have a lot of gastric cancer in Japan, in Eastern Asia, and we know this problem of stump cancer. It's genetically also predetermined, and we know it might take up to 30 years. So as MGB has been invented in 1997, we don't yet have this 30 years. So it might be that there is a small portion of additional malignancies at the gastroesophageal junction, adenocarcinoma at that place. It might be, there might be some cases, but I would be careful to discredit the procedure just for this, because we have to take into account how many malignancies we can avoid by bariatric surgery in general, and many other malignancies are much more frequent in obese patients, like breast cancer, the endometrium cancer, colon cancer. All these cancers are very frequent and are much more frequent in obese patients. And if we can treat obesity, we treat the risk of these cancers as well. We will diminish the risk to a normal level, and so perhaps there is some 2% more at that point, but it has been overestimated, and this discussion has been very, I will say, emotional. As I mean, you understand what I mean.
Sir, excellent, really, and I absolutely agree with you. I remember when last time we were in IBC Oxford, and one of the British surgeon, so he has presented at that time a data. This was a comparison between the obese patient who did surgery and patients who didn't do surgery, obesity surgery. This data, and it was amazing for me. There was 12 types of cancers more in obese people, so that as you have mentioned. So it was interesting, and at that time, I remember I have asked question. So maybe in future, one of the indication of obesity surgery will be prevention of cancers. Maybe. So
exactly.
we can think about, yeah, maybe in future. Sir, if we go ahead, today you were discussing about high risk patients. What do you mean high risk patients for MGB? Can you define? What is your definition?
I mean, high risk, there are several factors unknown implicating high risk in obesity surgery. There are different scores, like this obesity surgery mortality score. That's not all, but we know that like BMI higher than 60 is of course.
No, my question for MGB.
For MGB. Okay, yeah.
Only for
Understand. It's for MGB, you have to be careful with patients having diarrhea, because the frequency of stools will be a little bit higher. So you have some mild malresorption in MGB. So it is one risk, not a risk for the procedure itself, for perioperative complications, but for the risk having a bad outcome concerning aggravation of the diarrhea, or patients with some degree of fecal incontinence, and so having chronic inflammatory bowel disease. You have to be very careful. Concerning the risk, I think you mean more the risk of the operation. We try to operate on non-smokers, so we try to convince smokers to stop smoking before having MGB, because if there are ulcers, we have like 3.5 to 5%. We have ulcer complications, marginal ulcers, and about half to 60% of them are smokers. And to avoid this, we motivate smokers to stop smoking. And of course, we got in MGB no other risk factors than for other bariatric procedures. So meaning coronary heart disease, having stents in the coronaries. And so that's a more general problem in bariatric surgery.
No, sir, my question. Yeah, that is general. So no, if we see H, or have you any concern regarding H. pylori, and are you think there is a relation between H. pylori and marginal ulcer?
H. pylori, we are still trying to eradicate before, because the incidence in Germany is meanwhile like about 20% of H. pylori. So we are doing testing for H. pylori. So we want having a endoscopy before every MGB. That is 100%. So we don't operate if there has not been a endoscopic examination before. And we strongly recommend having the testing for H. pylori. But we are not, if it was not done, we would not insist. So it's quite more like a loose recommendation, and there might be some correlation between the ulcer rate and H. pylori, but it is not consistent. It is not a very strong correlation, I think. So so we wouldn't insist having, but still we recommend having testing of H. pylori before the operation. And if there is a positive result and there is time enough, we would recommend having it eradicated still. But this is questionable, and it depends very much on the incidence of H. pylori. So like in Portugal, I know there is a 85% of the population is positive for H. pylori. So there is no sense. So you could eradicate all your patients. And I think there is no sense, because probably there is a lot of resistance and they will recontaminate. And so it depends on your local situation. So I feel it has become a bit less important, this H. pylori issue.
Agree with you, sir. Sir, another question that is that, so because always this is a question GERD before surgery. Because again, I also GERD is a vast definition. So I will summarize. So what is the question? So if patient is documented reflux, it's not symptoms. So because routinely you do endoscopy before surgery, gastroscopy before surgery, and there is documented reflux. and you have documented GERD in this system, maybe Barrett. So Barrett, I know Barrett is very rare, but again, sometimes so you face in such a situation. So what is your routine practice? Because I am not asking what you think about this,
No,
but because this interview is your practice, what you are doing in such a case.
in patients having like severe GERD, having large hiatal hernia, but very important I feel is having very frequently symptoms or having symptoms daily and needing PPI on a daily basis to get rid of the symptoms. In these patients, we would be rather, I say, more restrictive doing MGB, meaning if we got, it depends also on the BMI and on the fat distribution type. Meaning nowadays, if I get a patient with a BMI less than say 45, having a lot of GERD, so in this case, I could do safely Roux-en-Y gastric bypass as well. So if he needs daily PPI in this patient, I would considering doing Roux-en-Y gastric bypass. But on the other hand, having a patient with a high BMI, where there is a risk for the to conduct the Roux-en-Y gastric bypass safely, it will be too difficult, and exposing my patients to the risk of the operation. In these cases, I would still go for a mini gastric bypass and just wait the outcome. And explaining my patient before the operation, there might be a risk that he needs a second operation after some time, after having lost weight. He needs some operation to focus on his reflux problem. If the reflux is not disappearing with a one anastomosis gastric bypass, then I would go in a second step, having like a hiatoplasty, gastropexy, reducting the hernia, and or even if there is a bile would be a problem, even converting to Roux-en-Y in a second step much later. But one anastomosis gastric bypass got a good potential to improve the reflux symptoms, because the stomach is pulled downwards, so the axial small hernias are reducted, so they are not existent anymore, and you have the low pressure system because pylorus is deviated, which is proven. So it is still a better option having mini gastric bypass in a high BMI patient than going straight for a sleeve gastrectomy, which will quite sure deteriorate your reflux problems.
Just as you have explained, just my question again about your experience. Have you did a surgery MGB in high BMI patient with severe GERD? What was the result?
Yes, we did. Of
regarding
course.
GERD.
Yeah, regarding GERD, we did, and the experience is mixed. So, meaning there is a part of the perhaps the bigger half of this group will have improvement. But there is a part of this, say, like about 30–40%, still having GERD, or even aggravating GERD. This might happen as well. So this is a group, and these patients you have to consider for a kind of revisional surgery or for doing anti-reflux surgery. I would not go for a larger hernia automatically in a primary operation in a high BMI having a hiatoplasty done. Sometimes we are looking the situation, the size of the liver, how you can access the hiatus, if it's safe or if it's more a risk, but very often we don't touch, and we say we are just happy doing our MGB and looking at the outcome, and then considering going in again after 2-3 years, if necessary, if not improved, if the patient belongs to the smaller group of patients where the symptoms do not disappear or even aggravate. Is this about?
Yeah, we have because a lot of questions. So I know due to shortage of time and already you have been tired. So, but again, regarding this GERD, again, we have a little different question. Same thing. So because you have mentioned, there was a mixed response, most of the patient, so relieved from GERD, but some literally maybe aggravate. Have you revised any case of GERD after MGB and you revised to Roux-en-Y or any other procedure?
Yes, we have. We have to revise some a group of patients like 3 to 4% for the moment in our total group of 1,300 primary MGBs. We had to revise for this reflux issue, and actually some even we did this conversion to a OAGB technique with the anti-reflux stitches and with a hyatoplasty, and but they were not all successful, and therefore I came back doing, in these cases, doing Roux-en-Y gastric bypass, which is quite easy, meaning I'm not routinely.
Excellent, sir.
Yeah. I'm not routinely redoing the GJ anastomosis. We are measuring the total bowel length, and if the efferent limb down to the ileocecal valve is long enough, then we preserve the pouch, we preserve the GG junction, and we are just doing like a 80 centimeter or even 50 centimeter only elementary limb connected to the end of the biliopancreatic limb, which had been cut off from the anastomosis, from the GJ anastomosis.
Sir, excellent. Sir, one question regarding GERD after sleeve gastrectomy or a patient with intractable, so this GERD after sleeve, and now you are going to revise this surgery or redo surgery. Have you any experience of MGB in such a case?
Oh yes, we have a lot of experience. Actually, I just have a paper submitted to obesity surgery comparing a group of MGB to a group of Roux-en-Y gastric bypass after sleeve as a conversion surgery, because we do both.
After a sleeve with GERD, not
with GERD also. Yeah, with GERD. Actually, it's a retrospective study only. It's not prospective, but there was outcome considering GERD was not significantly different. So in both groups, we got similar results, but we added in both groups, we added anti-reflux techniques at the diaphragm as well. So we did dorsal hyatoplasty, and we did the gastropexy, we fixed the pouch to the diaphragm. And so in both groups, we got quite similar results. But if there is severe GERD, still we would try more having, if really severe GERD, large hernia leads a lot of PPI, and so BMI is low. In these cases, we would rather go for a Roux-en-Y gastric bypass, which is not evidence-based medicine, but we are doing like this. Whereas in a patient with GERD and sleeve and still a high BMI and having a large liver, I think it is also a good option going for MGB and getting your diaphragm repaired, and it will resolve the problem as well. But we don't have numbers. We don't have final numbers of good prospective studies.
Yeah, I agree with you, sir. Because when we face this GERD after sleeve gastrectomy, so some cases there is a migration of this gastric tube inside, so thoracic region. Sometimes there is a kink, sometimes there is a functional obstruction. So yes, I agree with you. If there is no functional obstruction or twist or any kink at this incisura, So we can go for, as I have so understand from your discussion, we can go ahead for MGB. So now, sir, this is the time of technical points. So because most of our colleagues, and because I have received a lot of questions regarding this from Facebook just now, I can open. So if yes, questions, and also Dr. Mark also, he convey regards to you, Professor. Professor Mark, and also special, and also all the best.
All the best. Yeah.
And we have also, we have some questions. Yes, we have question from Professor Cure Yannick. So do you recommend managing GERD after MGB by doing hematoplasty? I think you have answered this with fundoplication with gastric remnant.
Yes, it's
you understand the question?
Yeah, I understand. It's a very good question. And actually, there is no evidence about this. But I admit that I did a couple of cases doing like a hemi fund application. I did it sometimes ventrally if the fundus is mobile and the vascularization is good enough. I did it ventrally, but I got the impression it does not have a lot of effect. But now I did few cases dorsally, so meaning behind the gastroesophageal junction, I pulled the fundus and I did a dorsal hemi fund application. And these very few patients, up to now they are all good, but it's of course it's only a very just an experience of few cases. So I cannot really tell you it is you must do this. So it is possible, but I will just tell you, you must be very careful that your fundus remains its vascularization, because it is in the remnant stomach. The fundus has only the small gastrics, the short gastrics, which are so you cannot just cut off all the short gastrics, and then you will have ischemia in your fund application, which would be a terrible complication. You should avoid this. But it is an option.
Professor Yagnik, hopefully you have received message. If you have another question, highly welcome. Sir, we can go ahead for your technical points. So you can show your video, you can show your slides, and so we are here.
Okay.
Up to you, sir.
Okay.
Yeah, just I will, then just a minute. I will add here, then you can share your screen. Now you can share your screen, sir.
Okay.
Yes, this green, share screen.
Yeah.
Yes.
So, okay. This is a video of a mini gastric bypass. We can stop it at any point if you want to see. It's 17 minutes actually. So just to inform you, this is the trocars, where we put the trocars. We don't use Verres needle. I'm using straight away optical trocar. Going in here, you see the fascia, the peritoneum. Now we are in the abdomen. I just stop here. Actually, this is the first trocar is in the left upper abdomen. This is also a point we changed. Before the first years, we did the first trocar here in the midline, so meaning paramedianally, 2 centimeters left to the median line. We did this first trocar, but we stopped this, and we are doing since a couple of years the first trocar in the left upper abdomen. I just recommend this because the risk to have a serious vascular complication here in the midline is much bigger than if you go on the left side. Especially the mesenteric veins, superior mesenteric arteries, they are just quite close here, which might cause a serious complication. So I recommend going with a first stroker in this technique on the left if you don't use varus needle. Just a small point. We continue. This is a look downwards to see whether there are adhesions or whether your small bowel is mobile. Then we don't use liver retractor routinely. As a surgeon, I am on the right side of the patient, and we pull down the fundus slightly. And Dr. Rutledge does not like this, I know, but I still like it to cut a little bit these adhesions above the fundus, not really to make naked completely the angle of his, but just to have between the upper pole of the spleen and the angle of his to have some exposure, which will facilitate the end of your vertical staple line. And even if you just create some bleeding here, when you come from the greater sac behind the stomach, you will see the hematoma there, and it will help you. The hematoma will help you finding the place where your staple line should end up here. So now this was a pylorus, here's a angulus, and we are starting on the small curvature, like 3 centimeters below the angulus. Here's the incisura, and we go here. This is a pylorus here. So it's quite low, and there you have to be careful not to injure the capsula of the pancreas, which sometimes is very close to this place. And it's you see the pancreas you have seen.
Yeah.
Yeah. And I take this is with echelon from Johnson & Johnson, and in which you got the different colors with this kind of device, and we use a black, which is the biggest, the highest staples, and this is what I said. This was very important. This to pull in the minor curvature, into the device, and not to start your stapling here, to avoid the twisted pouch. This was very careful, very important, And you have to leave a bridge of about 2.5 to 3 centimeters here to get drainage of your remnant stomach. If it's too small, you might have a obstruction, and your remnant stomach will fill up with fluid after a couple of days. Now the vertical staple line, we start with a green one, which is a bit lower. At this point, without any calibration tube for the first vertical stapling. Dr. Rutledge does it a bit more towards the greater curvature, to have this cobra-shaped pouch. I'm doing like a mixture. It's quite large, our pouch, but perhaps 4 centimeters of width, the lower end. And now, by introducing the second vertical staple cartridge, we are pushing forward the calibration tube. It's coming now from the anesthetist is pulling it downwards. We are stretching the stomach downwards, and now it's coming. This, you see the calibration tube. It's not so important the size, the diameter of this calibration tube, as you stay a bit away from it. You just have to be careful to have a similar width of the anterior and the posterior wall to avoid twisting of your pouch. This is now the preparation in the greater curvature behind the stomach, and here you have to be very slow, very careful. And here sometimes you have a hematoma from from the preparation at the first step of the operation, and you see where to go. Here's a spleen, upper pole of the spleen. Actually, this is already sufficient. Nowadays, I would perhaps stop at this point already. As I did a larger window here, but it's sufficient. And at the upper part, we are using a smaller stapling device cartridge. We use the blue one at the upper part because the stomach wall is much thinner at the upper part of the stomach. And we stay away like 2 centimeters lateral from the angle of his. You should not go closer to the angle of his than this. So the pouch is about 3 centimeters broad. The width is about 3 centimeters, 3.5. Of course, you always need to take off these metal, these staples, because they can be a cause of misfiring of your stapler if you leave them, and they may be in front of the knife. So now the stomach is completely divided, and for the gastrotomy, before doing the gastrotomy, we clear a bit the posterior wall, because I'm doing anastomosis on the posterior wall, coming from the lowest point of your pouch. So I have some surgeons are doing different. I know anterior wall, posterior wall. I think you have to take off a little bit. If there is too much of fat tissue, you take away. Our anastomosis will be here about on the posterior wall, and we are just going in at the lowest part, which is very often the crossing of the first transversal staple line and the first vertical. So this is the deepest part of the pouch. You can even take off completely this corner, because otherwise it will cause hassle with your finishing the anastomosis. So at the deepest point, we take off this staple line. Before the anastomosis, you have to pull back the calibration tube to not to take it into your stapling. Now we are just scratching the greater omentum upwards to come below. Here's the transverse colon, to come below the transverse colon and to expose the ligament of Treitz. And there's some assistant can help you to hold up a bit the transverse mesocolon. Here is the angle. Here is the ligament of Treitz with an inferior mesenteric vein on the left. And there we measure in 5 centimeter steps with 2 instruments, with 2 atraumatic instruments. Of course, it's not exactly 5 centimeters, but with experience now we know about. So we have perhaps it's plus minus 20% at the end, and it depends on the condition of the bowel, whether it is very contracted or you have you give buscopan or drugs like this. So it's very one day after it might be different, your length a bit. So this is an enterotomy. And of course, you have to be at all the time here. You have to be very careful to know where is your oral and where is your aboral part of the small bowel. Of course, so it's not you cannot miss this. So in case you would lose your small bowel, you have to remeasure, you have to know where is a ligament of Treitz and where is a direction to the ileocecal valves, because it would be a bad complication to go now in the wrong direction. Here you have to go in the direction towards the ligament of Treitz to get a good shape of your anastomosis, to get the bile coming from above and the food going down towards the ileocecal valve. And the length, it's very much discussed. So it's between 4 and 5 centimeters. I think most of the MGB surgeons would agree it is a good option. And now you don't push, you turn anti-clockwise your stapler. Very important for not to perforate your small bowel. It is not necessary to push because the pouch is long and your anastomosis is be placed just above the transverse colon. And you can pull your gastric pouch, but you should not push your small bowel because this is dangerous. Pushing the small bowel is dangerous. You could cause a perforation with your stapler, even with a large part of the stapler you can perforate. But you can pull hard on your stomach. So here we do about, 5 centimeters, about the length. And this is a bridge on the posterior wall. We try to have it like 1 centimeter below and above larger for the vascularization. But it might happen that it is very narrow. If it's very narrow, your bridge, you can bury it with your suture to avoid ischemic. This I don't do anymore now. It is since 2 years or so, because we do a wide anastomosis here and I don't need it anymore. But in the beginning, it helped me a lot. So I recommend for beginners to have your calibration tube pushed downwards in your efferent limb, as I did here, as I have shown here. But later on, nowadays I don't push it down. I just suture. And I try to have a wide anastomosis and I suture in a transverse direction and trying not to grab too much of tissue to have a wide anastomosis. It should really be wide. It should allow the bile going down into the efferent limb and the food as well to avoid reflux of bile into the upper part of the gastric pouch and to avoid bile reflux. In this case, we use a barbed suture. This is from Etikon as well. You got it from different brands. It's a 2.0. It's resorbable, but of course you can use other material as well, like Vicryl or like long time resorbable, like PDS or so. You can use. I wouldn't use non-resorbable material in this place. Perhaps some people do, but you can also staple this defect. Actually, you can staple it in a transverse direction. But for doing this, often I need holding stitches to push it up and to have the whole of this, to have the total hole, the entire hole in your stapling device. I need on each corner, I need a holding stitch and even sometimes in the middle. So it is quite troublesome doing 3 holding stitches for just to have one cartridge fired. So I feel it's a good option to suture it. It keeps you also in a well trained, because a bariatric surgeon needs to keep his capacity of suturing always alert. So you should not do a technique where you never suture, because sometimes you might need suturing in bariatric surgery. So you need suturing, and it's a good place to do a training of suturing. We do a double layer continuous double layer running suture. So we are going back. It's well vascularized, as you see, but by pulling on the stitch, it stops itself. So the stitches backward are more with bigger steps, and so here it's over locked suture, because you don't tie it, you don't do a knot at the end with this kind of barbed suture. You can put a clip as well, it's possible, but mostly I like to avoid clipping, unnecessary clipping, because these clips, if you do some redo or so, you must take them off. So you just cut it off, and you see your anastomosis, it got this kind of omega shape, it's not twisted. Before, when I did it in a wrong way, this part was lifted up, and I had to do an anti-torsion stitch. We are doing a blue testing, still I'm doing, not so much for the tightness of the suture, but to have an idea of the shape and whether there is a stenosis or so. And there are very rarely, it might happen that your stitches cut through, that you have a buttonhole defect at the suture, and you have pouring blue at this point. It might happen. It's some patients having cortisone or so before. The tissue might be very soft, and so I'm still doing this kind of testing. Some surgeons find it ridiculous to still do it, but it's not an obligation to do it, but I do it. So I just show my techniques. There are different techniques to do. I have followed other sessions, and I know every MGB surgeon does small variations. As I do drainage, so for some time I did not drainage, and I had a bad bleeding in 2012, and therefore since then it's perhaps more psychological for me than for my patient. I don't know. There's no evidence about drainage. We just leave the drain for 24 hours or for one night. So next morning the drain is taken off. So are there questions to this technique or comments?
Yeah, excellent, really. And in my opinion, the demonstration was excellent. And technically, there is no question. This is reality. And some of our colleagues, Professor Mark, also his comment, excellent, especially your demonstration about first trocar. As well as his question about, sir, why not using a liver retractor? This is the question from Professor Mark.
The liver, why I don't use liver retraction? I find it's not necessary, because by standing on the right side of the patient, I use my left hand with the instrument to lift up. I show this, you can see this? I think you see it. Huh? So with the left hand at the beginning, I am pushing up the left lobe of the liver, and I got the assistant is giving some traction on the fundus, and with my right-handed instrument with ultrasonic scissors, I can cut here. But of course, it is not like a dogma. So if you like having liver retractor, you can use it, of course. Or sometimes, very rarely, I use liver retractor if really you got a very, very huge liver and I cannot having access. It is not forbidden using liver retractor, but just in more than 95% of cases, I don't need, even in our super obese patients, I don't need liver retraction. But often I use a 10 millimeter instrument here in the left hand, because a 5 millimeter instrument, it might bend, and I might damage it. It's a 5 millimeter instrument.
Agree, sir. And also, hello from Professor Laurent Layani. He's also watching us.
Thank you.
Again, Professor Mark also, he appreciated your technique. So how you avoided the twist. That was the first stapler, and it was excellent demonstration. Sir, we can go ahead because due to shortage of time. So just maybe this is not last, but just second last question. Have you any bitter experience after MGB, like early bleeding or any early complication like leak? And how, if you had such a situation, how can we prevent ourselves from such an early complication of MGB? Now, sir, regarding this, you can stop sharing, then we can see you. This slide you can, yeah, stop.
Perhaps I got one slide which okay. Came in today. I wanted to show you because perhaps you never see it again in your life. I had one patient operated 3 years ago in our hospital 3 years ago, and today she is in a neighbor hospital, the patient, since some time, and she had got an MGB in my center 3 years ago. And now she was in a unit of thoracic surgery, or she still is in a unit of thoracic surgery, and she was operated there for pleural emphysema, and they did thoracoscopy, thoracotomy with decortication and drainage, and so. And now I have seen this picture, and. You see what happened. Actually, it's only now one picture, but it's a proof that there is a herniation of the remnant stomach. This is you must now believe me, because there are the other pictures, but there is a staple. This is a staple line of the remnant stomach. This is a part of the fundus, and she has a hernia. She has a hernia of the diaphragm, and the fundus 3 years later has gone up and has become gangrenous, has become necrotic, causing pleural emphysema. So,
sir, we cannot see. Sir, we cannot see your slides. Please share slides.
Sorry. Sorry.
Yeah, please.
Can you see now?
No, not yet.
Not yet, okay.
So just this, you can click first green, this share screen.
I did actually, but...
Again, you can click that.
Thailand.
Yeah, now I think, yes.
Now?
Yeah.
Now you have it, okay. So this is a CT scan of this patient with MGB and with pleural emphysema on the left side, and you see this white line. This is a metallic material. Is a staple line of the remnant stomach, meaning the remnant stomach has been slipped, has been herniated via a diaphragmal hernia into the thorax, and must become necrosized, gangrenous in the thorax, causing pleural emphysema. And it's probably, I think it must be a hernia, perhaps by thermal injury of the diaphragm, which is, of course, it's just my suspicion. I will check for it. I have not, but we will operate on this patient. I will take her over, and we will operate. But I think it's not a hiatal hernia. I think it must be diaphragmatic parahiatal hernia. So more in the central part of the left diaphragm, which might be a complication of my first step of the operation, which I showed. So this cutting down of the suprafundal adhesions, you must be very careful. And perhaps there was been some thermal injury to the diaphragm, has been cut too deeply, and during 3 years postoperatively, now this remnant stomach found its way to going up to the left thoracic cavity and becoming gangrenous. And of course, it's a problem which will be solvable. So we will resect the necrotic fundus and close the diaphragm. I just want want to show you what can happen. So even with experience, it is possible to create complications like this on a long run. So it's 3 years she was doing fine, and now she came with this problem.
Sir, really excellent demonstration, because now this was the excellent point. So during this dissection of that his angle, sometimes when we are dissecting, so maybe, yes, you have highlighted. So this dissection at earlier stages is also helpful for last stapling. And what personally I do, I put a gauze there. So that is my guide. Because sometimes when we dissect from so posterior side of the stomach, so we are blind. So we are dissecting. We have no idea where we are going. And when I put a gauze there, yes, then at that time I chase that gauze, as well as you have mentioned, you chase your hematoma. So at that place, that is also helpful. And then there is, and again, my request to my youngsters, this is typical point. So when you are at that place, be careful, especially ultrasonic, because the arm, hot arm can damage that diaphragm, as well as can damage that EG junction at that side dissection, can damage to spleen. So these are the main points. Really, sir, excellent demonstration. And also regarding our comments, we have a lot of comments in Facebook from Laurent, from Professor Zafar Gondal. He is a consultant bariatric surgeon in Rashid Hospital, and also he appreciated your technique without liver retraction. It was amazing, and many comments we have. Sir, we can go ahead, and then now our maybe this will be second last. Have you faced any earlier complication like bleeding, or just regarding bleeding? So because or leak, because we have many other complications, but I want to, my target is bleeding, because there is more chance of bleeding after MGB. Have you faced such a situation?
I have faced, of course. I mentioned that I had some time I did not put any more drains. It was in 2012, and then in 2012 I had one. It's actually in the whole series. It's only lethal outcome with primary MGB. I had in 2012. It was a patient having severe postoperative hemorrhage from the minor curvature. So from the branch of the left gastric at the level of the first table line in the minor omentum towards the liver at this point, and he was obviously bleeding heavily. It was only a few hours after the operation, and we took to theater, and he had even this own blood transfusion, this cell-saving procedure we did, and with an open procedure managed first to survive, but he had like a post-hemorrhagic shock and organ damage, and he died on the day 31st post-operative day. After 1 month, it was with a renal failure and all these problems. So it was quite a bad case for me. It showed me what bleeding might happen, and since then I addressed a lot to this problem of bleeding to avoid a second case like this. And okay, we restarted putting a drain, but the drain is not giving security to avoid a major severe bleeding. What we are doing, what I learned in Belgium at the hospital in Brugge, a hospital from Dillemans. There is Professor Mullier. Professor Mullier is a bariatric anesthetist. He's an excellent chap, and he focused. He did a lot of research on this bleeding issue in bariatric surgery. And what we took over is we are raising up the blood pressure at the end of the operation, meaning 10 minutes before our prospective end of the operation. We asked the anesthetist to lift up the systolic blood pressure like at least 120, 130 millimeters mercury by injecting adrenergic drugs like ephedrine or noradrenaline, so they are lifting the blood pressure, so we are provoking oozing and bleeding, and I know the companies don't like this because it looks as if their staple lines are oozing all a lot, but for the patient security, I found this it was very useful, because then we can apply either clips, mostly clips, yes, or you can do oversewing, of course, if you have a bleeding in the fatty tissue or so, or you can use like this things like resorber cell or something like this collagen fleece, this tissues, resorbable material, hemostatic agents you can apply locally on your staple lines to be sure when you leave your patient, you provoke the bleeding, you stop the provoked bleeding, and then you have less chance having major bleeding postoperatively. In my unit, this was very successful, and additionally, we are putting patients normally not on ICU on a normal ward, but they have just for one night, they have this telemetric device, meaning they just get their oxygen saturation measured and their heart rate, and the staff, the staff in the ward, they can watch on their central place. They can watch about the heart rate, and if it's going up to more than 100 or 110, it will give you an alarm as a signal. Or if the saturation, oxygen saturation drops, also you have an alarm, and the doctor in charge, surgeon in charge, can come and can check the patient, doing ultrasound and doing all is necessary to avoid major bleeding of these patients, because this is, in my opinion, the major cause of postoperative death. If in just this first 12 to 24 hours postoperatively having bleeding. You can also, during the anastomosis, you can look into your anastomosis and even apply, if there is something, some bleeding, pulsating bleeding in the anastomosis and on your staple line, you can even put a clip inside.
Are really excellent, and also, in my opinion, this is a great message for all of us, especially for youngsters. So, just sir, last question. Any message for youngster who are going to start MGB?
Yes, the message is, of course, you must be, before starting, even if it's quite a straightforward operation, but you must be, you need some solid basic abilities. So you must know stitching, and it's not sufficient just having done a few gallbladders or hernias or so to doing this kind of operation. You need some training to be sufficiently experienced in stitching. Of course, if you have somebody experienced as your assistant, it is something else. But starting it alone, on your own responsibility, you need to have this kind of abilities before.
Sir, really appreciable, and it was a great informative debate. Especially, I have learned a lot from your experience, and hope this will be a great message for my viewers, and especially for my youngsters. So MGB, OAGB is a good surgery, but in good hands. Need to expertise. This is not simple surgery. If you follow technical points, then there will be less chance of complication. Sir, really appreciable, and thanks a lot for your great support. And same, my viewers, we will continue our debate about this series of MGB, OAGB. And next week, we will have another expert of MGB. And most of you know him. He is Nasser Sakran. He has a great experience about MGB, and next week he will be our guest. And if you have any question about MGB or OAGB, you can ask earlier, you can ask during our debate, and hope next week we will see you with Nasser. Thank you, sir. Thanks a lot. Have a nice time, sir.
Thank you very much, Professor Abba. Thank you very much. It was a pleasure being with you. I really enjoyed. I felt honored having been invited. Thank you very much.
Thank you, sir. Thank you, sir.
Thanks. Have a good night. Thanks.
Good night.
All the best.
Yes, sir. Thank you, sir. Just a minute.